Dear colleagues, here is Dr. Katz from Hamburg, Germany, and I would like to share with you my experience with a pseudoexfoliation mature cataract surgery. We can see that the pupil is not so wide, the capsule is difficult to recognize, so we use vision blue, and we need several movements. Here is accelerated, to make as large capsulorhexis as possible. It is important in pseudoexfoliation not to stress the capsule and to give enough room for mobilization of the nucleus. With the phaco we use the chop technique, in which we use very strong vacuum and less phaco energy in order to fixate the nucleus and separate it, pushing from the equator to the center. In this direction there is no much force exerted on the capsule or on the zonules. If we succeed, we can lift a quadrant or part of it higher into the anterior chamber and do the phacoemulsification there. It is also useful to protect the posterior capsule and to float the nucleus with viscoelastic through the cracks of the nucleus, and that way we have more flexibility in rotating and manipulating the nucleus inside the capsular bag without friction or rubbing with the capsule periphery or the posterior capsule. And it works very well. A large part is already exerted, and now we lift the rest of the nucleus, quite a large piece, into the anterior chamber. The endothelium was properly protected with enough viscoelastic and even more viscoelastic, and now we can chop this 3/4 of a nucleus easily under full visual supervision. We know exactly what we push and what we pull, and piece by piece we can remove the nucleus in spite of pseudoexfoliation syndrome and a small pupil. But please pay attention what happens next. I will show it in slow motion. After removing most of the nucleus, we can see here that the rest of the nucleus dives into the vitreous body. We can also see a tear in the anterior capsulorhexis at the 5 o'clock position. Since we are using eye drop anesthesia and intraocular anesthesia, we don't have too much options to play with, so we are forced immediately to perform an anterior vitrectomy, which was done. Of course, we can see the nucleus floating on the superior vitreous, but we cannot pull it up, unfortunately. The next unavoidable step took place 2 days later under general anesthesia. This is a pars plana vitrectomy, and we can visualize the nucleus lying on the retina. We cannot touch the nucleus before completing a thorough vitrectomy. We should release the anterior vitreous base, the central vitreous, and any part of vitreous that may be attached or covering this nucleus sector. So this nucleus was removed completely, and then we would use triamcinolone injection in the vitreous to demonstrate the residual vitreous that is still surrounding this area, and do a thorough peripheral vitrectomy. At the end of the surgery, the patient is aphac, and our take-home message is that mature cataract with PEX could be operated. We need a specific technique, but we also have to be prepared for possible complications and their management. Please join us for the next sessions of this case and similar. Thank you very much.